was approved and released for sale in the U.S. was that Regranex was applied inappropriately to chronic wounds. They did not heal, and it got a bad rep. If a wound bed is properly prepared, platelet-derived growth factor is a great, albeit rather expensive, adjuvant therapy for you to consider on your very difficult to heal wounds. But these are not resurrection factors. They're not Jesus factors. They're growth factors. If the wound bed is not properly prepared, you can put all the growth factors in the wound you want. It will not promote healing. The growth factor gets destroyed. The growth factor receptors are not on the cell. The matrix is denatured. They will not work unless they have a proper environment, like in an acute wound, in which they can function. One way, in just the last few slides, that I'll tweak some of your interest in is a new approach. Instead of using a preformed exogenous growth factor, ideally, the better way to deliver this is actually the transient gene therapy using a viral vector. That is a very, very effective way to infect cells and get them to express the growth factor locally. This is a diagram of what an adenovirus vector would look like. In this particular formulation, it's formulated in a collagen matrix. And here, my colleagues, David Mazingo, who's the head of our burn unit, and Karen Perrin, who is a nurse practitioner, the equivalent essentially of your district nurse and tissue viability nurse, applying this adenovirus vector expressing PDGF to the first patient ever treated. After one treatment, coming back after 2 weeks, the wound was about 80% healed. These 3 patients were all received a single treatment. All of them had very dramatic results. I'm happy to tell you that this has now gone through the end of the phase 1 dose escalating ranging study. There were no adverse events attributable to the adenovirus vector, and they are now entering into a phase 2 study to look at true efficacy of this compound. The reason this will, in my opinion, be an important adjuvant for you to consider is when those wounds don't heal appropriately, they need some fertilizer. They need some growth factors in many cases to push them into that wound healing modality. This is an extremely effective way to do that because it delivers physiological levels of the growth factor, not these pharmacologic levels that we have to use when we use something like PDGF and Regranex, because those growth factors diffuse away. They're applied once and they diffuse away. This is made constantly by the cells that are transfected. It lasts for about a week, and then the transgene disintegrates. So this isn't a permanent transduction. This is a transient transduction, and in this case, that's an advantage. Finally, some last examples, the bioengineered skin equivalents, Dermagraft and Aptograft in the States. Both of these are effective in randomized clinical studies, again, partly by replacing a matrix that is not denatured, but most importantly, they are essentially transplanting growth factor factories into the wound. If you transplant Dermagraft or Aptograft and the cells are not alive, they do no good. And fortunately, we learned that when a batch of Dermagraft was sent out and the cells were not very viable. There was no effect of those materials in promoting healing. When the error was realized and those were replaced with Dermagraft constructs that actually contained functional viable cells producing growth factors, they had the biological effect as expected. So these, again, are examples of where growth factors produced locally within the wound are going to be very helpful in promoting healing of difficult to heal wounds, but only in the context of when they're alive. And the final aspect, negative pressure dressing, is a technique that has gained enormous traction in the States. Many of the wounds that previously were considered for major free flap or pedicle flap based surgical procedures, massive surgical procedures in the States, are now treated initially with negative pressure, and actually negative pressure is an oxymoron. There's pressure and there's no pressure. This is reduced pressure, not negative pressure, but reduced pressure dressings actually promote granulation tissue and enable a very difficult, very large wound, in this case a sacral ulcer, to be closed down with enough to be improved with enough granulation tissue that it either close by itself or will allow a minor surgical procedure to improve it. So negative pressure or low pressure vacuum assisted closure is not a complete treatment. It helps to prepare that wound to get ready for a more minor type of procedure. How does it work? Some data that we've recently published suggests that within the first 24 hours, and it doesn't matter too much what the axes are here, but this is TNF-alpha, MMP3, MMP9, and the ratio of MMP3 to TIMP1. What I hope you see is that we start out high at the time the VAC therapy is applied. In the first 10 minutes, this is what sucks out of the wound. 24 hours later, if we take a 1-hour sampling from 23 to 24 hours, and we measure the concentration of these materials that have been shown to be elevated and we believe to be a problem in chronic wounds, within 24 hours, those are rapidly dropped and tend to maintain low levels throughout the rest of the treatment. So what this basically does is like it flushes the toilet. It just sucks all of those bad things out of the wound, gets them away, and allows that wound's molecular environment and fluid component to assume a more physiologically compatible environment with the natural wound healing processes. So what I hope to do in hopefully 40 minutes is to summarize for you some of the aspects of advanced regulation of wound healing. We reviewed very briefly a topic that you're very familiar with, that is acute healing. Proceeds through these 4 phases. Those phases are regulated by cytokines, growth factors, proteases, the matrix, and unfortunately, acute wounds that fail to heal and convert into chronic wounds have abnormal levels and imbalance in these key regulatory components, the cytokines and the proteases particularly, resulting in corrupted matrix components, low levels of growth factors and receptors, which makes it difficult for the cells to respond normally to those endogenous wound healing materials. Wound bed preparation is a concept that corrects these molecular imbalances by really helping you to systematically use good wound care practices. And that even when wound bed preparation is appropriately employed, there are some wounds and some conditions in patients that are so difficult to correct that you're going to have to consider the use of advanced adjuvant therapies within the context of an appropriately applied wound bed. And fortunately, you now have the choice of multiple approaches to do this, including antimicrobial dressings, protease inhibitor dressings, growth factor inhibitors, topical growth factors, engineered skins, vacuum-assisted closure concepts. And the last thing I'll close with is to just tweak your curiosity and to say that to help you even more, we are now have initiated a major project at the University of Florida to develop a wound diagnostic test strip that you can use at the bedside. And this, we hope, within a year or so, I may be able to bring you back even better news that says we will give you a strip that you can lay on the wound 15 minutes after you take that, and it develops much like a pregnancy, early pregnancy test strip. We'll be able to tell you if the level of cytokines, proteases, and growth factors are in a range that are conducive with healing, or if you have to go back and rethink wound bed preparation, try to address some of these abnormal properties and abnormal levels, and help guide you in the selection of the appropriate therapies to get that wound to heal. Thank you.